Welcome to UD Talks, the podcast brought to you by United Drug, Ireland's leading pharmaceutical wholesaler and distributor. Along with our host, Denis O'Driscoll, we're here to bring you the latest insights, trends, and innovations in retail pharmacy. Each episode, we'll dive into a range of topics that matter to you, from cutting-edge pharmaceutical developments to the day-to-day challenges faced by retail pharmacies. We'll be joined by industry experts to share insights and explore the future of pharmacy in Ireland. UD Talks is your go-to source for staying informed and inspired.
The content of this podcast is intended for pharmacists, healthcare professionals, and individuals with a professional interest in community pharmacy. While every effort has been made to ensure the accuracy of the content within this podcast, United Drug cannot accept responsibility for any mistakes, errors, or inaccuracies. Listeners are strongly advised to verify the information contained in this podcast with a relevant healthcare provider or seek medical advice where appropriate before acting on any information provided. United Drug shall not be liable for any loss or damage arising from the use of the information contained in this podcast. This disclaimer operates to limit United Drug's liability under contract, tort, including negligence, or statute. This disclaimer is provided to ensure that listeners are aware of the limitations of liability before they rely on the content. By continuing to listen to this podcast, listeners signify their assent to this disclaimer.
Hello and welcome to our podcast today on long COVID. I'm delighted to have Stefano Savinelli and Lorna Quigley here from Infectious Diseases. Stefano having a specialism in long COVID, and Lorna who is part and parcel of the rollout of the strategy around infectious diseases. So I'll start off, maybe Stefano, you might just introduce yourself, and then maybe Lorna, you might just introduce yourself and maybe give a little briefing about exactly what you do, because I know I gave a very broad sweep there for your introductions.
Good, thanks Dennis. I'm Stefano Savinelli. I'm one of the infectious diseases consultants working at St. Vincent's University Hospital, and I'm currently leading the clinical activities at the long COVID clinic here at St. Vincent's Hospital.
Thanks, Stefano. And Lorna, how are you today?
Thank you, Dennis, and thanks for the introduction. So I am currently the Programme Manager for the National Clinical Programme for Infectious Diseases. The clinical programme is new. It's only set up in the last couple of years, and I suppose the work of the programme is around plans for how we manage infectious diseases in Ireland. And part of that remit would include long COVID, which is what we're discussing today.
Thank you so much, Lorna. So on that, Stefano, let's get into the deep end on this. One of the questions I think that a lot of us just would like explained is the current understanding of what long COVID is, and maybe just a differentiation from, acute COVID-19 infection.
Okay, thanks, Dennis. So first of all, there is no standardized definition of long COVID. And the main reason behind that is that we don't really have anything to guide our specific diagnosis of long COVID, being it mostly a diagnosis of exclusion. However, there are some indications from the UK guidelines and the WHO definition of long COVID, and it's usually defined as the persistence of symptoms for longer than, depending on the timeline, some guidelines use longer than 4 weeks, or usually the more accepted ones consider symptom duration longer than 12 weeks after the end of the acute phase of COVID-19. And of course, it's quite different from acute COVID-19 in the sense that the acute illness is usually very similar to a flu-like illness with symptoms of upper respiratory tract infection, or sometimes, of course, in more severe cases, lower respiratory tract infection that will lead to hospitalization. Whereas in long COVID, we usually see more persistent of fatigue, shortness of breath, and other general symptoms that are quite different from the acute phase.
And Stefano, you just said there that it's kind of hard to differentiate. I guess then, because it's a relatively, and I don't mean, not to sound kind of facetious or anything, a relatively new phenomena, the whole long COVID piece, I reckon then that there's no way of determining how long symptoms last for long COVID, because it's still ongoing, I presume, the research around it and the understanding of the disease etiology.
Yeah, exactly. So it's quite hard to establish exactly how long it lasts for. It really varies a lot among the different patients. So most of the people will actually recover within 6 months. But unfortunately, there are some that will have lingering symptoms for even for years. We have some of our patients come into the long COVID clinic that we've been following since the beginning of the pandemic in March 2020. And unfortunately, they don't seem to improve in their symptoms. So it really depends on the patient. But luckily, most of them will recover within 6 months or a year. But for some of them, symptoms unfortunately last for a longer time. And we don't know how long it will last for. Yeah.
So it's like a piece of string. You never really know. And it always sounded so individualized to patients. So it's much harder to, I presume, then to kind of give people health outcomes on that because it's so individualized to patients themselves.
Exactly, yeah.
Okay. So Lorna, over to you. I guess my question is just around how long COVID ended up in infectious diseases. Whilst I appreciate like COVID is an infectious disease, how long COVID came about and how the program was able to pivot to include that into the strategy.
Thanks, Dennis. So I suppose all of this happened before I came on the program, but I understand that, as you say, the infectious diseases consultants were pivotal in the management of COVID. It was around that time that the National Clinical Programme was commenced. And I suppose because of the large role and the very significant role that ID consultants had, and I suppose that long COVID was new, we didn't know about it then. So the ID consultants were managing COVID patients. So it kind of came from that. And I suppose, again, so there was an interim model of care developed around long COVID in 2021 that I say, again, Stefano was involved in. So he might be able to answer better on that as well. So I'll revert to Stefano to add more to what I just said there.
Thanks, Lorna. So Stefano, I guess 2021, we are looking after long COVID. Have you seen like things change? It becoming, I don't want to use the word acceptable because that sounds wrong, but seen as like it is a real, how people might perceive it as, is it a real disease or is it not a real disease? You know what I mean? Not to be disrespectful to anyone who's suffering with long COVID, but that kind of misconception out there by the public.
Yeah, thanks, Dennis. That's actually a good point. So unfortunately, there's still a lot of skepticism around long COVID. A lot of physicians really struggle to understand what it is. And probably the main reason is because, as you know, we don't have clear criteria to define long COVID. But that doesn't mean that people are not experiencing those symptoms. So like people are actually really struggling with those symptoms and they can't get on with their activities. So, but I suppose generally there's probably been an increase in the understanding of long COVID, especially among primary care physicians, I have to say, because they're probably the ones that are more involved in the management and they actually see the patients in their practices. But you're right, unfortunately, there still is a lot of skepticism around that. And some people just think that it's just part of being tired and stuff like that. But it's actually more complex than that.
Okay. And Stefano, just to continue to lead on from that. So somebody presents at a clinic, I appreciate you said between 4 weeks is some of the timelines after acute infection, but usually after 12 weeks. So when they present, what would you say the most common kind of symptom that they would present with?
Yeah, so the most common symptom is definitely fatigue. So people are describing this extreme sensation of tiredness, and which is not only waking up tired in the morning, but also feeling tired throughout the day and not being able to carry out normal activities. This also reflects most of the times in what we call post-exertional malaise. So people experiencing extreme fatigue and a general sense of being unwell as well, not only after physical exercise, but also after activities that would put anyone into a bit of stress, like work-related activities or any chores, even house chores like doing the laundry, or sometimes even simple things like having a shower could trigger symptoms of post-exertional malaise. And then I think the other big one would be what is described as brain fog. So this inability to concentrate or to process information, having issues with finding words when you're speaking, or forgetting basic things like where you left your keys, and mostly in the realm of a short memory rather than long term memory. Yeah.
And Stefano, do you see many with cardiovascular issues associated with the long COVID? Why I'm asking that question is that I have, like everyone, I have a friend who was diagnosed with long COVID, and one of their was fatigue, extreme fatigue, but the other one was a kind of change in the heartbeat. There was a slight change. I don't know if it was a prolongation or a shortening, but there was a change in the heartbeat for them, which then affects their tiredness levels, if that makes sense to you.
Yeah, so that's a good point. And issues with palpitations and other cardiac issues are actually quite common in people with long COVID. We used to see that more often earlier on in the pandemic, mostly because people were probably referred to us in the very first few weeks after the acute infection. So it's quite common, of course, between 4 to 12 weeks after the onset of acute COVID to have issues with shortness of breath, palpitations, and more from a cardiac point of view, or chest pain, chest tightness. Those were things that people and our patients were describing. And we don't see that as often now, but still a lot of people present with palpitations. And most of the times this could be also related to what we call autonomic dysfunction, which is quite a common feature of long COVID. So this regulation of the autonomic system, which regulates the heart rate and the respiratory rate. So people would have issues with inappropriate tachycardia or issues with dysfunctional breathing that are still quite common in long COVID, yeah.
Okay. And Stefano, from your perspective, for the tiredness and the extreme fatigue and for the other kind of symptoms, is there a prescribing regime you do, be it by a library piece or, exercise or kind of adding more into your day to improve your kind of ability to carry out normal functions? Is there a pattern that you'd use for prescribing, or is it also individualized, that there's no like common theme through that prescribing process or that allocation of treatment options?
Yeah, so thanks. This is an interesting question. So I suppose management of long COVID is really individualized. So it depends really on what symptoms the patient is reporting, and so based on that, sometimes we do prescribe, at least in my clinic, I do prescribe medications for symptom relief sometimes, although that wouldn't be, for example, for fatigue. Like if the main symptom is fatigue or post-exertion malaise, there isn't really any specific medication that would act on that, mostly because we don't really know what the mechanism behind that is. So it's hard to find a medication that would address that. Whereas if someone comes in with aches and pains, of course, there's some medications that we could use for pain management or headaches, or for heart dysregulation of the heartbeat. Sometimes we can use medications that would normally be prescribed, like beta blockers or ivermectin and other medications like that. But it is mostly individualized, and there isn't really there are no specific guidelines on how to manage specific symptoms. It's all based on our experience and our knowledge from other conditions that might behave in a similar way to long COVID, like fibromyalgia or migraine or chronic pain or other conditions that are normally managed with medications.
Thanks for that, Stefano. Lorna, from your perspective, with regards to the programme and the way that the programme is rolling out, just for infectious disease in general, how would you see the role of a community pharmacist, being part of the infectious disease programme, prevention, treatment? Where would you say that they'd be best placed in order to help influence the public health initiative around infectious diseases?
So I suppose that a large part of infectious diseases is prevention. So I suppose any public health measures that will reduce the risk of infection. So things like infection prevention control, things like hand hygiene and sanitation. Also things like vaccination is obviously a very prominent issue. So vaccination against any infectious diseases.
So Lorna, just sorry to cut across you, but just that leads me beautifully into vaccines and COVID vaccines in general. Would you then see that that we should be, that there's a bit, I'm going to use a little bit of lethargy amongst the population around vaccinations. Because they've been so highly vaccinated. How would you see that pharmacists could encourage their patients to take the COVID booster this season? Because we're obviously coming very close to it now. What would you see would be really important? Because there's and this is only rumor that I've been reading through, like the CDC, and we currently have the JN1 variant. But then I see that there was a something issued from the CDC, and I'm sure Stefano, you'll correct me on this, on an XCN variant or something like that, and that we should be waiting for this other booster shot. What, any opinion on that? Where should we just take the booster that exists now because that will offer us some additional protection?
I would say I'm probably not the best place to answer that. I mean, we have to listen to advice, like a national advice, and what comes out around vaccination. Obviously, we know vaccination is extremely important to try to prevent infections. And I mean, we're even seeing it recently, I suppose, in Gaza, where we've seen polio come out that hasn't been there in years. So it's just to be aware of that with regard to...
So you're saying encourage people to take the vaccine that's there, that public health have issued, to say, please use this vaccine. This is the vaccine you should get.
Well, I think we have to listen to public health. They're the best place. The experts are involved.
Perfect. And Stefano, over to you with regards JN1, or that newer one that I saw, XCC, whatever. I know I got the name wrong, and I should have done my homework a little more, but I only read the paper over the weekend. I've been asked by a couple of patients saying, "Oh, Dennis, is this a better one to wait on?" And what I've said for my advice, and just to make sure that, is that the JN1 is the one that's available. That's the one that you should get. It will protect you against other variants that are coming forward. Would that have been a fair comment to give across?
Well, I think so, Dennis, in the sense that, of course, there will always be new variants. That's what COVID does. We've learned it in the last few years that unfortunately tends to mutate, and there's always new variants coming along. But that doesn't mean that even with the newer variants, there is always some level of protection that the vaccine will offer. It might not be the ideal one, but still, first of all, these circulating variants might be predominant in some areas, like for example in the United States, when they do a lot of surveillance. We don't really have the same mechanisms for surveillance here in Ireland. It's not as widely available as it is in the US. So while we do know which strains are predominantly circulating here in Ireland, it doesn't mean, first of all, it doesn't mean that they absolutely reflect what's happening in the United States. And there's also the point that there is definitely some level of protection from previous vaccines towards the newer variants. So bottom line is, I would definitely defer to the public health advice and follow their recommendations.
Thank you, Stefano. And just a question then on a long COVID patient coming in for a COVID vaccine. Is there any differences that I have to do as a pharmacist if they come looking for a vaccine, or are they like treated like any other patient? Is there anything that I need to be mindful of before offering them that vaccine or providing them with that vaccine?
So I think they should be treated as a general population. There is some evidence showing that vaccination against SARS-CoV-2 is actually quite effective in preventing long COVID. And the other thing is that many of our patients with long COVID will unfortunately have a relapse or a worsening of their symptoms with subsequent SARS-CoV-2 infection. So it is a good thing to get vaccinated to prevent reinfections, which might worsen your symptoms. On the other hand, though, there are some people that we're seeing in clinic that are actually referred as potential vaccine injury. For those people, we still don't know what the right management is, in the sense that those people started experiencing symptoms of long COVID after a vaccination event, most likely. And in that case, it's really hard to tell whether they should get a vaccine or not. Most of them are quite reluctant, and probably have a reason for that, because they temporarily associate their symptoms with the vaccine. But that's an area where we don't really have much evidence on. It's still a bit of a gray area. So in that case, it's very hard to give them some advice. And I would just, I think it's a personal choice, and we should respect their personal choice whether to receive the vaccine or not.
Okay, thank you. And I guess to both of you, and I don't mind who answers it, as a pharmacist, is there anything that I could be doing if a patient does come into the pharmacy and from talking to them, you think, is there anything in that we could do with early identification with regards to long COVID? And if so, is there a referral pathway, or what is the referral pathway that we'd have to undertake, or will we just refer them back to their GP? Lorna, do you want to take it as a fellow pharmacist? I'll throw it at you as a fellow pharmacist.
I suppose, pharmacists should be aware of kind of asking leading questions, I suppose. If somebody has had a recent COVID infection, what are the symptoms? How long is it since then? Have they been tracking their symptoms, I suppose? And to get a better understanding of whether or not they need to be referred to a long COVID clinic. But I suppose the first thing is that they would revert to their GP if they have symptoms. And then there is a GP referral pathway that will refer them into a long COVID clinic. And from there, they will be seen. So obviously, they'll be seen by one of the ID consultants, and then they'll be referred on as needed and to other services. Also, there's a multidisciplinary team in there. So if they need things like health and social care professional support, that's all available through the clinic as well. I think as a pharmacist, a lot of the role is around counselling, helping them with self-management. I suppose just to be aware of, the need. I mean, obviously, because there's a range of symptoms and, obviously people want treatment for their symptoms, to just be cautious of using medicines that they might find on the internet or somebody else might suggest to them, to always go back to the GP, because there isn't a lot of evidence-based treatment. So just to be careful of that. And I suppose just to make sure that they have support to spend time listening to them, I suppose, again, keeping a diary of their symptoms, etc. And I suppose to know where resources, if they want to look themselves, there is information on the HSC website. There is information on self-management supports on the WHO website. So just, I suppose, to provide them with as much information as possible. And I would just say that, the pharmacists aren't involved in the long COVID clinic. So I think that the role of the community pharmacist then becomes more important, because, there hasn't been a pharmacist involved at any point up to then.
Okay. So what I'm hearing, Lorna, is just your usual practice as a pharmacist to find out how the patient is, see what their symptoms are. I think the diary idea is a fantastic idea. I use it all the time, particularly for patients with mental health issues when they start on a new medication. As I call it, my good day, bad day diary. That's what I refer to it as. What was interesting is you said that there's no real kind of validated medicines out there that will heal, get rid of long COVID. And I guess, Stefano, I'm going to throw that back at you, because this is a question that you will be asked by patients. So they'll ask, should I take an immune booster herbal medicine? Should I take this? Will that help me? Should I take vitamin B? Should I take vitamin D? Where do we stand with supplements and the provision of additional supplements? Is there harm in providing them, or is there there may be some perceived benefits in it for the patient themselves?
Okay, thanks. This is a tricky one, I'd say. Unfortunately, there's very limited evidence on any intervention for long COVID. Actually, the only thing that, based on if you go and look at the HIQA report on the interventions for long COVID, the only thing that has some sort of evidence behind it is it's actually a multidisciplinary approach with health and social care professionals, like Lorna was mentioning. So the role of physiotherapists, occupational therapists, psychology, and so on. In terms of medications, there's usually when patients come to me to ask, my approach would be symptom directed. So if there is a specific symptom that can be addressed with some medications, we can try and address that. Let's say shortness of breath. Of course, if it is an asthma-like presentation, you could do a trial of inhalers, as you would do with someone with asthma, and see if there is an improvement in their symptoms. Again, with chronic pain, you could go with tricyclic antidepressants that are commonly used for chronic pain and other stuff, and you could see whether there's an improvement with that. Outside of that, like the use of supplements or other herbal products, there is absolutely no evidence behind that, and they're usually quite expensive. So I always tell the patients, if you feel that they're being beneficial to you, I doubt that there's going to be any harm, but of course it's going to be quite expensive for you, and I'm not sure if it's doing anything to you. So and of course there are also some products that might be potentially associated with side effects. So if there is no evidence of any benefit, my view would be not to use them until we have more evidence to support the use.
Yeah, so that's a really interesting point. Just in pharmacy, you get asked all the time. My immune system's down, or maybe if I improve my immune system, this will all go away. So it's important to note that to be mindful if they are taking other supplements, that they make sure that when they go back to the long COVID clinic, that they inform the prescriber there that I've started on one product over another, just so that you're aware that they've started on it. The other question, Stefano, that I have for you let's say I have a patient in my pharmacy who has long COVID. Is there anything that I would need to keep an eye out for with regards to their ongoing treatment care, with regards that maybe they need to be referred back urgently back to the long COVID clinic? Let's say they have an appointment and not for 6 months from now, but something, is there anything that I need to keep an eye out from, looking after them out in the community pharmacy to say, I really think you should go back, make an appointment back with Stefano in the clinic?
Yeah, so I suppose, of course, like most of the symptoms that we're dealing with are not particularly life-threatening or concerning, but of course they do affect their quality of life quite a lot. So if there has been, and this can, of course, potentially lead to a deterioration in their mental health as well. So if this is really affecting their everyday life, they can't carry on with their activities, they're not able to go back to work, and maybe the management, the strategies, and the medications that are being prescribed are not effective at all. I think in that case, it would be worth mentioning to them, maybe you should reach out to the clinic and see if they can see you any sooner. Let's say they have an appointment 6 months down the line, and we always tell our patients that we're more than happy to get in contact with them if they need to see us any sooner. However, most of the time, it is something that can also be managed in the primary care setting. And in that case, I would defer to the GP, as you know, the long COVID clinics have quite a long waiting list in many cases, and we're seeing quite a high volume of patients, so we might not be in a position to see them any sooner. But we can also offer virtual remote consultations, so we could reach out to them and see how things are going. So.
Okay, and thanks for that, Stefano. Lorna, I guess from your perspective in the whole program in infectious diseases, and I'm going away out into infectious diseases, not just on long COVID, do you see that the whole area of infectious diseases is, I hate using the word blossoming, but we're seeing more and more presentations with infectious diseases with regards our sexually transmitted disease piece, that it's on the rise? Or is it that COVID somewhat masks some of that, and now we're seeing a bounce back? I don't know if I'm making sense in that question, but you understand what I'm trying to say, that the reporting of these would dropped off and now it's suddenly peaking up again. Is it because that during the COVID times less reporting came in, or is it that just people are going back to activity?
I would say that there was just very much a prominent focus on COVID. The others certainly didn't go away, and there was certainly still surveillance on them. And yes, there is certainly a rise in some infectious diseases. I suppose I think that probably community pharmacists, and hopefully over time, will be able to play a more prominent role to kind of relieve the burden in both the acute services and primary care, to help out with infectious diseases, and particularly sexually transmitted diseases.
And Lorna, that's an interesting point there that you brought up. So I guess where you mentioned the community pharmacists could help, would you see where particularly they could contribute to these public health initiatives from your perspective as the program manager for infectious diseases? Where would you see the ideal kind of contact points that you could see a community pharmacist being involved with, just in infectious diseases in general?
Well, I think that, there are a lot of diseases and infectious diseases that are managed through the acute setting that I think could certainly move towards primary care. And again, things like HIV, maybe they don't all need to be driven through the clinics. Other sexually transmitted diseases, I think there's roles around testing, counselling, a lot of services that are provided through the acute setting. I think that, community pharmacists are ideally placed to manage these. And it is happening in other countries as well. And I suppose we just need to be aware of the burden on the acute setting. So whatever can be managed in the primary care setting. Now, obviously, there are large challenges in Ireland. The countries are more advanced, particularly around technology and healthcare records, etc. So, at present, it's very hard to see any time in the near future. As I say, because of access to information is very difficult. But hopefully, there is scope into the future to try to move some of the services out.
Yeah, no, and I agree. Probably that's the biggest impediment is the access to shared patient records. Like if you had that, I think a lot of kind of the issues that where primary care can help acute and acute can help primary care would be, I won't say ironed out because I think there'll always be little kinks here and there, but it certainly would make the information flow much more open, transparent for the people who need to know it. Yeah, interesting point. Stefano, back to you, and not to put you under more pressure with regards clinical and all clinical information. With regards long COVID, is there anything that is prescribed that is like unusual that you might see in a pharmacy being prescribed, or is it generally like, as you said, symptom specific? So if it's like tachycardia, you might give them a beta blocker. For tiredness, there's not a lot you can do. Is there anything like unusual that you've come across in research that is kind of like, I don't know how that works. That's a very interesting kind of scenario, you remember during COVID, we were getting things like anti-worming tablets would prevent you getting, ivermectin will prevent you getting COVID. All of these things. Is there anything that has come across your desk that you're looking at going, isn't that interesting, but it's really kind of a little bit out there at the moment?
So thanks, Dennis. This is another tricky question. So I suppose from my point of view, I haven't seen any good evidence on any medication that is prescribed for long COVID. So my approach is usually to address symptoms. And I believe this is the common approach in the publicly funded long COVID clinics across the country, and in general in long COVID clinics outside of Ireland as well, in other countries like the UK and so on. I know that some physicians prescribe other medications that are not really licensed for long COVID. I have no experience of the use of these medications, and usually when people come to me asking for my opinion on these, I always say to them that I wouldn't prescribe something that I'm not familiar with and that has no evidence of any benefit. And I always remind them, because sometimes people will come to me and say, oh yeah, but I have a friend that was prescribed this medication and now they're feeling better. And I always tell them that in medicine, we use a different approach. This would have to be studied in a randomized control trial. The fact that one person is experiencing a benefit from a medication doesn't mean that the medication is actually working from them. And there might be other factors at play. Some people might feel better even just with paracetamol. And that doesn't mean that paracetamol is active against long COVID. So that's what I always tell them. And there's also usually an economic burden of some of these medications that are extremely expensive. And I don't think it's justified to use them until we have the evidence to support their use. And of course, there could be also potential side effects, which we might not be overly familiar with, given that we wouldn't prescribe them normally.
Okay. And so that, Stefano, leads on to a question on, from your perspective as a clinician, you've identified throughout what you're saying that there's gaps in our knowledge around long COVID. We actually know it exists, but it's really hard to determine. We can't give a determinant that you'll have all these symptoms associated with long COVID. And equally with treatment, that there seems to be a lack of research. Is there, from your perspective, what are the real gaps in the knowledge and research regarding long COVID, or is there more gaps that really need to be infilled before we can actually look at those as kind of the gaps?
Well, I suppose the approach should be the approach we use in any other type of disease or illness. Like, we know what the mechanism behind certain clinical manifestation is, and then we use specific medications that act on those mechanisms. So for example, if you're treating an infection, you know what the agent causing the infection is, you know that agent is susceptible to specific, let's say, antibiotics, and you're going to prescribe those antibiotics because they work on that specific agent. If you don't know what the actual reason behind specific symptoms is, it's very hard to decide how to act on those symptoms because you don't really know what the mechanism behind them is. So I think the main gap in research is trying to identify what the mechanisms, the pathogenetic mechanisms of long COVID are. There's a lot of research on this, and many studies have been published around this, but we still haven't identified, let's say, a specific marker, a specific target that you could effectively use to address long COVID issues with long COVID. Yeah.
Okay. And from your perspective, and I guess, Lorna, this will be to both of you again, but we'll throw it to Stefano first. Clinical trials, any clinical trials and any interesting meds that are out there, or is it kind of just not happening in clinical trials with regards to this disease? With regards to treatments, is there any clinical trials you're aware of with new medications, Stefano, that is?
So there are a few trials happening around the globe. I'm aware, for example, of a current trial in British Columbia looking at the use of low-dose naltrexone, which is one of those medications that we probably some people are being prescribed in different settings. Nothing has come out of it as far as I know. It is a trial that is still enrolling patients, and so we should have more information in the future. There have been trials on other compounds. They're all still ongoing. The ones that have been published have very low quality of evidence, to be honest, mostly because either of the small numbers of patients that were enrolled, and the other issue is the definition of long COVID. So in most of the cases, it is not standardized, it's really hard to understand what we are addressing. So these people might be presenting with different symptoms completely, and so that's why it's very hard to understand whether the interventions are effective or not, because they act on a multitude of symptoms, and so probably a more individualized approach would be easier, but that's very hard to do in a clinical trial setting, of course.
Okay. And Lorna, from your perspective, you mentioned earlier about education, that there's websites well worth for pharmacists to go to. Where exactly were those again? One was where in the HSE?
So that would be more for the public. The HSE.ie have a section on long COVID, so you can get information there. The interim model of care, I suppose, just for the pharmacist reference, which has information on the clinics and the GP pathway, is available on the HSE website as well. I think it's on Clinical Design and Innovation website, which is the website where all the clinical programs put all of their information. And there's a very good article in the Pharmaceutical Journal, the British Pharmaceutical Journal, that was done, I think, in 2021 around kind of how pharmacists could help patients. And it is around, the counselling, the piece around the counselling, self-management and diary. And then, as I say, there were self-management symptoms, I think they're very basic, but done by the WHO, that, again, might be of benefit to patients. So they're kind of resources for patients. And then pharmacists, there's very little out there at the moment, and there's very little that pharmacists can refer to in Ireland, but there are some journals done internationally.
Okay, thanks a million, Lorna. And Stefano, this is going to sound like a really odd question, and maybe I should have asked it at the very start. Do we know, is there a percentage who could be affected with long COVID, or is it like that's the unknown question? Like, is it like 10% of those who got COVID get long COVID, or is it like that's an unknown, Dennis? It's impossible to say, or do we have any kind of idea around kind of how many, or what's the risk of long COVID, I guess is what I'm looking.
Yeah, thanks, Dennis. So this is an interesting question. I think it's probably getting harder to answer this question now because many people probably don't even test for COVID anymore because it's, of course, the public health recommendations around testing as well as have changed compared to the beginning of the pandemic. But based on the data we have from the initial cases of long COVID, so it depends on, first of all, on the definitions that you're using. If you think about symptoms lasting for more than 4 weeks, it's probably a higher percentage of people that would be affected by it, probably even more than 20%. But if we're looking at a definition of long COVID around like looking at duration of symptoms for more than 12 weeks, some of the data from the UK and other bigger cohorts from the US as well show that the prevalence, the risk of long COVID was between 5 and 10% of those affected by COVID-19. In more recent times, with the newer variants like the Omicron variant, and further variants, it's probably a bit less than that, probably around between 1 and 5%. But that's also probably because of the vaccination programs, because many of the people that are affected by long COVID are actually, that could be potentially affected by long COVID, are actually partially at least protected by their immunity through vaccination. As we know that vaccination from multiple studies is quite effective in preventing long COVID to some extent. So I think that probably we're seeing less of it now. It's hard to tell because we don't know how many people are actually affected by COVID-19 at present. But those are the percentages that came out of the older studies.
Lorna, as a pharmacist, and you have pharmacists out there listening to this, what would you say is, from your perspective, both from a long COVID and from a public health in infectious diseases, what is the best thing that we could go away with in order to bring into our practice tomorrow?
Again, a huge part of COVID long COVID is the emotional and social aspect of it and the effect that it has on the quality of life. So it's not just around medicines. So while we have a role in counselling and obviously helping with the medicines, I think that, we need to be aware of even asking questions around support, what kind of support they have at home, just to be conscious of people's mental health, because obviously it's having a huge impact on people that are suffering from it. So I think that, a lot of, if people come into community pharmacies for emotional support, it's not just about the medicine. So I think just to be very conscious of that, listen to people and make people, feel that they are being heard, I suppose would be a big thing around it. Because as you say, sometimes there can be a bit of skepticism, often when you don't visibly see symptoms, people can be skeptical of what's going on. So I think for me anyway, a huge part is that piece. It's the emotional support that you can provide them, and just to let them know, they're not alone. I think even that they're not alone, there is help out there, and just to reach out for support if they need it.
Okay, thanks, Lorna. And Stefano, over to you. From your perspective, as a pharmacist, I heard you there saying people should get vaccinated, that it does help with their immune system. Other than that, as a pharmacist out in the community pharmacy, from your perspective as a infectious disease consultant running a long COVID clinic, is there anything more that you would like a community pharmacist to be able to provide to your patients from your long COVID clinic, for example?
Thanks, Dennis. So I would just basically reiterate what Lorna was saying. I think it's important to keep an open mind on this and to avoid being too skeptical about long COVID. People we need to bear in mind that these people are actually struggling a lot because many of them are not able to work and they had to change their life completely around their symptoms, and some of them are facing also financial difficulties as a consequence of that. And there's a lot of stress around that because all of a sudden they're not able to make ends meet, or they might be struggling with their physical health and their mental health at the same time. So I think we should always bear in mind who we have in front of us, that it's someone that is not getting on well with their lives. So trying to be understanding, and as Lorna was saying, trying to support them as much as we can, and most of all, acknowledge the existence of a problem, and not brush it off as something that they're making up themselves, because it's clearly not the case.
Okay, thank you so much for that, Stefano and Lorna. So on that, thank you so much for coming on to the podcast today. I think that this area is an area that is probably evolving faster than we all think, and we'll see by this time next year probably more and more interesting research and more interesting interventions that can be put into place. And again, thank you, Stefano, ID consultant, Long COVID Clinic, and Lorna, Programme Manager with Infectious Diseases in the HSE. Thank you so much.
Thanks
Very much, Dennis.